Because hardly 20, 25 or 30 students. 60 students are having. There is no attendance. Then they told there is attendance shortage, then they tell we are coming. You understand? Then once there is shortage of attendance, then people say we are coming. Who is telling we are not coming? So you can yourself see who is coming, who is not coming. How can we with this?
Yes, sir. हुआ सर.
Okay. Let me come directly to the topic. So today's topic is
Conjunctivitis.
Conjunctivitis. Conjunctivitis, as you know, conjunctiva is the outer layer of the eyeball. It is the outer layer of the eyeball. It has two parts. One is called palpebral, other is called bulbar. And in between there is a fornix, which is in the fornix of the lid. Okay. So anatomy you will read yourself. Once we say conjunctivitis, it means simply inflammation of the conjunctiva. It means inflammation of the conjunctiva. The inflammation of the conjunctiva can be broadly classified in two categories. One is the infective process, other is the allergic process. One is the infective process, other is the allergic process. So if you understand, both allergy and infection can lead to conjunctivitis. It can lead to conjunctivitis. Let's go directly to the infective process. What are the causes of the infective process? There are generally three main causes. There are generally three main causes. Clinically, if we see bacteria, clinically, if we see infective conjunctivitis, generally it is because of two. Because of two, bacterial and viral. Bacterial and viral. So viral, in my opinion, is more important. In my opinion, is
More important.
Why it is important?
Because no specific treatment is present.
Okay. Why is this more important? Why is more important? Can you keep it you? So why is it more important? Why? Because viral is more, it is more epidemic proportion. It is more epidemic proportion. It spreads very fast. It spreads very fast. So what are the main viruses which cause conjunctivitis?
Measles.
So always tell common things first. Measles also causes conjunctivitis, no doubt about it. It is not the number one cause. Number one cause adenovirus. It is adenovirus. Remember what? Adenovirus. Okay. Number second is what? What after adenovirus? What other virus causes?
Rhinovirus.
No. Other causes are like herpetic conjunctivitis, herpes virus, then measles virus, okay, herpes virus, measles virus, then even Coxsackie virus. Coxsackie virus. Coxsackie virus. So these are the common causes of viral conjunctivitis. These are common causes of viral conjunctivitis. Now, how does it present? How does it present?
Redness of eyes.
So there is redness in the eye. There is a first. Let's talk in a systematic way. What are the symptoms of viral conjunctivitis? There is watering. There is redness. There is watering. There is redness. There is in viral. There is more of watering. There is more of watering. There is no mucopurulent or purulent discharge. So you remember this is a clinical difference. In viral conjunctivitis, there is more of watering. Okay, that differentiates it from
Bacteria.
bacteria. Yes, that differentiates it from bacteria. So once there is a watering, then you have the redness. Then you have the redness. Then you have the photophobia. Then you have the photophobia. Aversion to light. Aversion to light. Then there can be lid reaction like edema. Edema of the lids. That also common. Then redness I have to. Then watering I have to. Then when does the photophobia or blurring of vision? Once there is corneal involvement. There is not only virus do not cause conjunctivitis, it can cause keratitis also. It can cause keratitis. So these are the symptoms. These are the symptoms. Then signs. Once we examine these patients generally, the vision is almost normal. Vision is almost normal. Cornea is initially clear, or it can have some punctate keratitis, dot-like ulcerations, or there can be subepithelial opacities later on. I will tell you about that. So generally, the globe is normal, vision is normal, but there is a congestion. There is a congestion. That congestion is more in the fornish. That's more in the fornish of congestion. If you tell the patient to pull down the lid, you will see the congestion there. That differentiates it from what? No. Bacterial also you have sick fornish of congestion.
Allergic.
No.
Levitis.
Allergic में थोड़ा सा है कि that fornish congestion is not that intense, but mainly in more serious congestion of the eye, like corneal ulcer congestion, circumcorneal congestion, uveitis congestion, scleritis congestion. You understand? Intense congestion is mainly on the globe. In this, the congestion is mainly in the fornix, either the inferior fornix or the superior fornix. Did you understand the point? So this is the clinical correlation of this congestion. Then one more most important clinically is in adenoviruses. There is a pre-auricular lymph node. There is a lymph node which is enlarged in front of that classical of adenovirus. That's classical of adenovirus. So you can always also see conjunctivitis. You can see whether there is pre-auricular lymph node. Okay. Next is skip the slide. Okay, keep it. So once we have done this, then we want to see that what are the preventive measures for spreading the viral conjunctivitis. How we can stop it.
Hygiene.
First is the hygiene, hand washing.
Proper hand washing techniques.
Hand washing, number one. And you should tell the patient not to touch the eye. Suppose I am a doctor, I am sitting in the OPD, I see 10 patients of conjunctivitis every day. There is a professional hazard to me now. There is a professional hazard to me. So I should not try to touch the lid too frequently. And once I see any patient of conjunctivitis, I should sanitize my hands. You understand? That is how we have been surviving for decades. Though we have suffered ourselves due to conjunctivitis. So other mode of transmission is omites. Anything like hankies, towels, they can secrete. Okay? Other mode of secret, suppose you are shaking hands with someone. So it can secrete. So patient who has a conjunctivitis, don't shake hands with. Okay? Then other is the overcrowding, like Hajj, like any big gathering, religious gathering anywhere, it can spread fast. Even in camps. So
Hostels.
overcrowding areas, it spreads very fast. So one should try to avoid going to those places if there is an outbreak of conjunctivitis. Then one more important thing is in the medical practice. In the medical practice, suppose a patient of conjunctivitis comes to the OP and somebody reports an intraocular pressure in the tonometer. And same kind of tonometer is being used in other patients. This is an instrument related separation that happens in the IOPDs. You understand? So it can separate in the medical setup, like a OPD setup, by contamination of the instruments, especially tonometers, especially like short tonometer, like applanation tonometer. So once one patient is infected and it gets impregnated on those tonometers, and once we check the next patient eye pressure, it will get transmitted. So these are some of the transmission routes which I have told you. So one should abide by the precautions, because always in viral, prevention is better than cure. There is no direct cure. Okay? There is no direct cure. There is no drug which we can give to treat viral conjunctivitis. The viral conjunctivitis treatment is supportive. It is supportive. Suppose we give cold compresses, we give just antibiotics as a prevention of suppressed infection, we give decongestants or antihistamines to decrease the congestion of the eye, we give some lubricants to flush out the inflammatory mediators. You understand? So it is a sort of a supportive therapy. Or we give sometimes antibiotic ointment at that time, again for suppressed infection. The only drug some people say can be given is ganciclovir. It is ganciclovir. Though we don't routinely give it. And generally it's a self-limiting disease, but it takes time. Like it takes 1 week, it takes 2 weeks, like that. It takes 3 weeks. You understand? So it's a self-limiting disease. So you have to just give a supportive therapy. Then after suppose 10 days or 15 days, some people develop corneal opacity, or after punctate keratitis, they develop subepithelial opacity. And those subepithelial opacity can affect the vision, and that's called nimmular conjunctivitis. What's called? Nimmular keratitis. Sorry, not conjunctivitis, nimmular keratitis. That's basically an immune-mediated response. That's sort of allergic response to what? To the viral antigen. What happens? In that what happens is that the seborrhea diffuse because they are pumping keratitis. Then they become that sort of opacity. Opacities are round, but they are subepithelial. They are subepithelial. They are at the Bowman's layer almost. So, top just epithelial cover, but subepithelial opacity, and they cause very drastic decrease in the vision. And once they happen, people generally give steroids. They give steroids. So once they fall affection, you give steroids. Once you give steroids, then they decrease. But once you stop them, they again comes. Okay, this is a big problem. You cannot continue steroids because that can cause glaucoma, that can cause cataract. No, topical steroids does not cause Cushing's. That's a systemic steroid what you are taking. Topical generally causes two things. Number one, glaucoma as a most common disorder of topical steroids, and number second is it can cause cataract. So you can not continue for 2 to 3 months or 1 or 2 months, then what do you do? So we give immunomodulators. Cyclosporin or tacrolimus. Cyclosporin or tacrolimus. So we take the steroids and then in the meantime we continue cyclosporin and we take the steroids and continue cyclosporin. So cyclosporin it takes minimum 2-3 weeks to have an effect. Till then we are continuing steroids. That's how we withdraw the steroids and continue. But by and large, in the long run, it gets resolved. But by steroids and immunomodulators, not by exclusion. But while giving steroids, you have to be careful of the recording of the intraocular pressure. Some people develop IOP, rise and glaucoma. So that's a very dangerous situation because conjunctivitis will not destroy the vision of the person, but glaucoma can. It can devastate the vision. So you have to be very careful. If such things happen, then you have to add anti-glaucoma or you have to reduce the frequency of steroids. And you have to substitute steroids with immunomodulators. So this was something about the viral conjunctivitis. Now we come to the, I think I made it clear.
Yes, sir.
Huh?
Yes,
If
sir.
anybody has any confusion, you can tell me. Then we go to the bacteria.
Bacterial.
The presentation is same, almost same, except that there is lipedema, there is congestion of the eye, there is redness of the eye, there is only thing is there is a mucopurulent or purulent discharge. In viral there is watery discharge. That's the clinical difference. So you have mucopurulent purulent discharge, then you have lipedema, then you have redness in the eye, then you have you can develop corneal complications, you can develop if the infection goes to the cornea. So then if we see the causes, what are the causes of bacterial conjunctivitis? So these are causes of bacterial conjunctivitis. We generally divide into three. One is acute. Right. Acute means Staphylococcus aureus, Streptococcal aureus, Streptococcal. Okay? Staphylococcus, Streptococcal, or the pneumococcal. And then you have hyperacute. What is hyperacute? Within 3-4 hours, the conjunctivitis becomes very fast, and there is a greenish discharge. There is a greenish discharge. In what condition it happens? It happens in no. Pseudomonas corneal also happens. In conjunctivitis, pseudomonas does not have much to gonococcal and Neisseria meningitis and Neisseria gonorrhea. These are the two which cause hyperacute. The conjunctivitis is very fast happening. Within 3-4 hours, it becomes very severe and there is a greenish discharge. Then you have chronic conjunctivitis. You have a chronic conjunctivitis. Chronic conjunctivitis happens with Staph aureus over a long period of time, and other important is moraxella or even chlamydia. Moraxella, chlamydia, and Staph aureus. Okay, they can cause chronic conjunctivitis. Okay? So, if now somebody tells you, what is the difference between infective conjunctivitis and allergic conjunctivitis? What should we answer? First I will tell, infective or bacterial or viral conjunctivitis is unilateral to start. It will affect the right eye or the left eye. It will not affect both eyes initially. Then it can separate to the other eye. But beginning, it will affect the one eye. Allergic conjunctivitis by default affects both eyes. Because allergy is bilateral. Allergy is bilateral. But we have seen also unilateral allergy. Remember. But that's very minuscule of allergic conjunctivitis. So, suppose out of 10,000 cases, one case may be unilateral. That's very rare. But generally, by definition, allergy affects both eyes. It's a bilateral. And number second, important thing I will tell you, that there is a watery discharge or there is a mucopurulent or purulent discharge. In what? Infective conjunctivitis. What about in allergy?
No discharge.
Watery and what else? Mucus. Mucoid. Ropey discharge. Mucoid discharge. It's not mucopurulent. Okay? That's the second. And number third, generally in infective conjunctivitis, whether there is viral or bacterial, as I told you, there is fornical condition. There is a fornical condition. But in case of allergy, there is predominantly perilimbar or globe condition on the mild condition on the globe. Okay? And that's not severe. Generally, that's mild to moderate. That is mild to moderate. While in case of infective, whether viral or bacterial, it is severe fornical condition. It's a severe fornical condition. So that was about the viral and bacterial. Viral and bacterial. So if suppose you have now bacterial conjunctivitis, how will you treat it? We will give broad spectrum antibiotic drops. Which type of antibiotic drop? We will suppose we will give quinolone 4th generation. Okay, like gefloxacin, or we can give ofloxacin, like that, or ciprofloxacin. We can give any type of antibiotic like that. And we additionally give antibiotic ointment at the bedtime so that it covers during the night. Okay, then we can give lubricants. Then we can give antihistaminic congestion drops. Those things, well, almost the treatment is same for viral or bacterial. Because viral we give only supportive treatment. But in bacterial, the treatment is specific to the bacteria. So this was about the bacterial, viral and bacterial conjunctivitis. So there are some things I want to highlight. Suppose gonococcal. Gonococcal. What will happen? A neonate is born, he develops conjunctivitis while he is born. You understand? What you will do? So you will not give only antibiotic drops, you have to give systemic antibiotics. You have to give systemic. Generally people give 125 milligram of ceftriaxone intramuscularly. Okay. So in adults you can give penicillins, or you can give this if there is a gonococcal conjunctivitis. And you have to see the gonococcal, you have to see the pattern of transmission, and you have to see the sexual partners, you have to screen them. You understand? And the presentation of gonococcal, I told you, is hyperacute with a greenish discharge. Is it? Hyperacute with greenish discharge. So this was something about the gonococcal conjunctivitis. Or this was something about the neonatal chlamydia, neonatal gonococcal conjunctivitis. Okay. Then we have one major class that's called chlamydia. trachoma. That's called trachoma. That's called trachoma. So trachoma is caused by what? It's caused by chlamydia trachomatis. Okay? Chlamydia trachomatis. Next. So this is the corner discharge showing that there are corneal ulceration in spread the cornea. Hyperemia means redness. What does chemos mean? That's swollen conjunctiva. As fluid is in the conjunctiva. Next. So suppose this presentation, there is discharge in the eyes, there is a conjunctival injection, and there is a mucopollular discharge. That speaks that it's a bacterial conjunctivitis. Next. So stop here. So chlamydia conjunctivitis is divided into three. It is divided into three. One is trachoma, one is adult chlamydia keratoconjunctivitis, and third is neonatal. Okay. Trachoma is caused by A to C, A, B, C serotypes. And adult chlamydia keratoconjunctivitis is caused by what? D, E, K. Okay, very good. So it is caused by D to K serotypes. So it is a sort of what is the predominant symptom in this chlamydia. So it is now waning off in the body. It's not that frequent now it was previously. So what it does is that it causes itching or foreign body sensation. Itching, foreign body sensation in the eye. Then itching causes subacute type of presentation. It's not that acute, it is not sort of a subacute to chronic presentation. Then it leads to a sort of a discharge, mucopollular type of discharge. Okay, then it can lead to follicles and what's the other name? Papilli, and no, there's some name. Papilli and I think papilli and follicles. Follicles or something else that's called. Okay, I will tell you differently. Papilli is sort of it has a central vascular core, hydrovascular core. They are small. So then we have another is the that has a white in the center that speaks of fibrosis with surrounding fibrovascular band type of thing. So in papilli, it means a sort of acute inflammation. It means a sort of acute fibrovascular proliferation, which is in the center. And in follicles, there is a central pale area with surrounding type of fibrovascularization. Did you understand the point? This is one difference. And papilli are very small. They are very small. Follicles are bigger. Like papilli can be 0.1 mm or 0.2 mm, while follicles can be even sort of 2 mm, 3 mm like that. They are bigger. So what leads to this chlamydia? It leads to a fibrosis stage. Then what is the presentation in the eye? What will happen in there? First, I told you there will be itching, there will be subacute conjunctivitis, follicular conjunctivitis. Then there are some changes in the cornea. There's some findings in the cornea. What's called, there are some pits on the limbus. Pitting. Pitting is due to scar. That's due to scarring. Those bits are called herboid bits. Those bits are called herboid bits. And there is one more, there is vascularization in the cornea. That's called pans. That's called pans. And once there is vascularization in the cornea, it will lead to corneal opacity. It will lead to corneal opacity. Once it will lead to corneal opacity, then if the vascularization goes ahead of the corneal opacity, it's called progressive pans. It's called progressive pans. Then one more thing, it causes fibrosis in the leads. It causes fibrosis in the leads. If there is some dorsal fibrosis, it forms a line in the dorsal plate. That line is called Arter's line. That's called Arter's line. Next. So it is a chlamydial infection in neonate. Next. Here, just I want to demonstrate one thing. They have a follicular type of response. Follicle. Follicle means a white, what I told you. Daptic means reddish. Follicle means white and bigger, with a very follicular type of vascularization. Then this is a scarring Barton's line, what I told you. This is the dorsal plate like this. This is the horizontal like this. So this is the what called herboid spits I told you. This cornea. This is cornea, and there are pits here on the limbus. There are pits on where? On the limbus. So limbal pits are called herboid spits. And cicatrization in the dorsal plate is called Arter's line. Then you have a acute follicular response in the dorsal conjunctiva. A whitish zone surrounded by fibrovascularization. What differentiates it from daptic? Daptic is a central fibrovascular zone with a small size. So long term it causes, once there is conjunctivitis, there is fibrosis in the eye, what it can cause? It can cause entropy of the lesion. Cicatrization is occurring from the conjunctiva in the eye. So it will pull the lid inwards, what's called entropy. And once entropy will happen, what will happen? It will cause trichiasis. The lashes will rub the cornea. Okay? So these are the complications of this disease. So it can lead to entropy, it can lead to trichiasis. So then you have to treat those things. So what is the treatment for this disease? Which antibiotic we give for chlamydia? Tetracycline. So tetracycline is the drug of choice for us. Okay? Which other antibiotic can you? Erythromycin. So you can give systemic. You have to give systemic as well as topical. And you have to give for a prolonged period. Not for 10 days, 15 days. You have to like 2 months, 5 months, 6 months like that. So don't tell you give for 10 days or 5 days. You understand? So it has to be given on a long basis. Like 2 months, 3 months, 5 months, 6 months. So how it is separate? How chlamydia separates? Huh? It's separated by fly. It's separated by fly. There is one fly which separates it. And sanitation is the main form of control. Okay? Sanitation is the main form of control. Because it is there where there are dirty things. You understand? Where the sanitation is going, it's spread by flies. So those are the, because they are supposed from SPM point of view, is a vector control. There is sanitization. If you control those flies, their population, it will not spread. If you control the sanitation part, then it will not spread. So those are rest. I have told you how to, what are the prophylactic measures for spreading the conjunctivitis. So that this. Next. I have noticed all this. Only thing is molluscum, I forgot. Molluscum contagiosum. That's a small waxy nodule on the lips. Waxy nodule on the lips. What is the classical of molluscum contagiosum?
Softening.
No. What is the region like?
Pearl. Black.
Umbricated. So once the region is like that, it is depressed in the center. Once you see a central depression, it is molluscum contagiosum.
Black.
Not depression like umbricated. Depression in the center of the nodule. Depression. So once you see a central umbrication, it means molluscum contagiosum. Once it causes conjunctivitis, generally it is allergic. It is not infected. So we give steroids in molluscum contagiosum cases. Okay? We don't give antiviral or anything. We give steroids, low dose steroids. What is the cause of hemorrhagic conjunctivitis? Yes, very good. Coccicuitis. So coccicuitis causes hemorrhagic, subconjunctival hemorrhage in both eyes. Okay. What is the cause of adenovirus? Epidemic. There are some serotypes. Some serotypes. What causes epidemic? Serotype 8, serotype 19 and 37. 8, 19 and says that cause epidemic type of adenoviral conjunctivitis. Here I will highlight one more thing, important thing, is that I have told you some differences between allergic and infective. One major difference clinically is in allergy you have predominant symptom of itching. Itching. So once patient will complain of itching, most likely it is allergic conjunctivitis. If the patient is complaining of mucopurulent or purulent discharge, most likely it is bacterial or viral. Okay? So itching is the predominant feature of allergy, and discharge is the predominant feature of infective conjunctivitis. Next. There is one pharyngoconjunctival fever. This is adenovirus. There is upper respiratory tract infection with conjunctivitis. Epidemic I have told you in detail. Next. So these are some of the features of adenoviral conjunctivitis. So in this there are predominantly peptide. Okay? There are peptide. There is central fibrovascular core. Then subconjunctival hemorrhage, I told you, as you rightly know, it is due to coccicuitis. Next. I told you something about neural characters. I have told you something neural characters. That begins with the punctate characters. Then there are subepithelial opacities. There are nodular subepithelial opacities. It responds to steroids. It responds to immunomodulators. It is a section of the cornea. It's a section of the cornea where we have some subepithelial opacities. There are subepithelial characters, what I told you. And this is a immunological response to the viral antigen. Okay? It's like this. She is right. It is like this. This is cornea. From this to this is the cornea, and this is cornea like this. Okay? And suppose this is point. This reflective, hyperreflective force is the subepithelial opacity. Okay? Next. Okay. Molluscum, I told you that it is a sort of like this here. Here, this. this form. This is a waxy umbilicated. Umbilicated, I told you. It's waxy umbilicated. And it was allergic type of conjunctivitis. It was allergic type of conjunctivitis. Yes? This is herpetic. If you have vesicles on the legs, it can cause conjunctivitis also. And that can be of two types. Either it is simplex or it is zoster. So you have to differentiate between the two. If it is simplex, there will be some vesicles on the legs like this. If it is zoster, then the peripheral dermatome will be affected. That we can judge clinically. That this is simplex or this is zoster. Next. So we move now to the allergy part. So allergy we have one is you remember four types of conjunctivitis allergy. One is allergic conjunctivitis. What is allergic? That is seasonal. That is seasonal allergic conjunctivitis. Other is perennial. Other is perennial allergic conjunctivitis. How many are there? Two. Then you have one catarrh. Then you have another catarrh. How many? Three. Then you have giant papillary conjunctivitis, GMC. So I will be discussing these four. And these four are separate. I am sorry, I forgot to tell about one bacterial conjunctivitis, Moraxella. How does it? What type of virus it creates? This is a condition in the palpebral fissure medium near the medial. Okay? There is condition near the medial canthus, like this, medially or from the conjunctiva, in the palpebral fissure. Not temporally, nasally. That's it. And we give broad spectrum antibiotics for this. So, now the first thing in allergy is simple seasonal type of allergy. Seasonal, you know, it will happen in a particular season. Okay? It will happen in a particular season. Which season is more common? Spring is okay. Cold, but summer, okay. Or you can see like March, April, like that. In Kashmir. March, April, huh? Because why? Because there are pollen. You understand? So, if it is a season, it is in this pollen season. So, there develops a conjunctivitis. What is the difference between seasonal and perennial? Perennial means throughout the year. Seasonal means in a particular season. That's the difference. Why there is throughout the year? What is the cause of perennialness?
Dust.
Yes, very good. It is dust. It is dust. So there is allergy to the dust. That will happen throughout the year. And you know the redness. Again, the symptom will be itching. Okay. Then the rashness. Then on examination there will be some redness on the globe. Okay. And there will be watering also, some amount of watering, and if there will be coordinate involvement, patient can have photophobia. So how you treat simple allergic conjunctivitis or seasonal allergic or perennial allergic? No, we give antihistaminics or decongestants. We give antihistaminics or decongestants, and we give mast cell stabilizers. I will tell about once I will discuss Gordon about those drugs. Okay? Just I have given a broad. So seasonal is in a particular season. Perennial is throughout the year. Seasonal is due to pollens. Perennial is due to dust. This is the difference. So let's now come to the main, that is the, suppose there are, you can see, remember all these things, itching, watering, redness, eye congestion, hyperemia, lymphedema, papillary reaction in the dorsal conjunctiva, then that I will tell you later on, truncaus, dots, signs, lids swelling, hyperemia. Oh, there is redness in the eye. As I told you, there are two things. One is the redness, that's called hyperemia. And one is chemosis. Chemosis means swollen conjunctiva. Okay, so there is both hyperemia and swollen conjunctiva. And in the lips, there is a papillary reaction. There is a papillary reaction. Papillary reaction, as I told you, there is a central fibrovascular core, and that is the raised type of vascular type of region. That's called papillary. That's called papillary. And cornea can be really involved. That's true. Next. So this is the most common. This is the most common. First, before I discuss this, what is the cause of allergy? What type of reaction?
Type 1
So it is type 1 reaction. What do we mean by type 1? It's an IgE
mediated.
It's an IgE mediated. Remember this. So seasonal or perennial is the IgE mediated. What's released in that? There is a histamine release, okay, by the mast cells. So that causes the conditional damage. Very good. Now we have one character conjunctivitis. It is a special form of character conjunctivitis. It's a special form. What is special about this? Special about this is that it starts from the childhood. It starts from the then it continues almost up to 22 years. Okay, so patient comes and he has a bilateral eyes are affected, both eyes are affected. Then he has the sex predilection points is that boys are more affected than girls. Remember this. What? Boys are affected more than the girls. Then, classical about this is there is a typical mucoid ropey type discharge, which is talked in case of verbal cutter. That's a ropey discharge. There is a ropey discharge. And classical about this is that it happens in siblings. It happens in siblings. So before I go to the science and classification of it, first let's tell what is the pathogenesis in this. Is it the same type 1 hypersensitivity or it is something else? Anybody? It is IgE mediated, but it can be non-IgE also. So it has two mechanisms. It has with IgE same, what is allergy. Okay? And non-IgE is a T cell mediated. Okay? That's a T cell mediated allergy. So it can be of three types. It can be of three types. What is the first let me tell you about some things in the pathogenesis what can cause it. One I told you that's allergy. Okay? IgE mediated. Other is the genetics. The parents are having verbal cutter, their children have also verbal cutter. Other is the dust. Other is the UV radiation. So those all things are adding together. This is composed. It is not a simple allergic type of like IgE mediated. So it has IgE and non-IgE mechanisms of occurrence of the verbal cutter. So clinically we divide it into three. One is palpebral, that means leading movement. One is the globe bulber, that's the globe involvement, and one is the mixed both palpebral and bulbar. Once you write, then add these things. Okay? Palpebral, bulbar, or limbal, or mixed. Okay? Now we come to the palpebral. What will happen to the palpebral? There are follicles. There are follicles. Sorry, there are pepti. There are pepti. There are pepti. Next. So, once there are pepti on the dorsal plate, they can be bigger. They can go bigger. What are those called? Yeah? Cobblestone. What's that called? Cobblestone. Cobblestone. So there is a grayish hue. There is a grayish hue of the dorsal conjunctiva, and that can become big, like cobblestones. The way we are seeing cobblestones, the appearance can resemble that. That's why it's called cobblestone appearance. Okay. Then we have the limbal form. What is the limbal form? Limbal form is this. On the limbus, there is gelatinous nodules, follicles. Okay? Gelatinous follicle or nodule on the limbus or conjunctival thickening with rabbits. And you can have one more, then you can have some white dots. These white dots, like this. And what are these white dots called? Canthal spots. They are called canthal white. What they contain? What these canthal spots contain? They contain this pigmented epithelium, but they contain something else. What cells are increasing there? Eosinophils. So they contain eosinophils with this pigmented epithelium. So predominantly they contain eosinophils. So remember this. These are white dots at the levels within these nodules or gelatinous nodules. Then these white dots contain eosinophils with what? With this pigmented epithelium. So this is the limbal form. This is a limbal form. Then you can have, this is not only conjunctivitis. This is conjunctival keratitis. So it can be the cornea also. What it causes in the cornea? No, it does not cause opacity. What it contains? It causes diffuse keratitis, punctate keratitis, dots like this. That's called diffuse keratitis. What is the diffuse keratitis? Diffuse keratitis is like this. Suppose this is cornea, there will be mild abrasions from the cornea like this. They are stained with fluorescein. They are stained with, you put fluorescein into the cornea, then you can see these dots. That's called diffuse punctate keratitis. Okay? What else it can cause? Next. Suppose these dots. Are you seeing these? These green dots, This is punctate error. This is punctate error. Then he has this one more. Suppose this will increase like this, it will become a big ulcer, right? This is called macro erosion, big epithelial erosion. Generally, it does not happen, but generally we have a punctate epitheliopathy. There is one more thing which can happen in Baramulla. That's called shield. That's called shield ulcer. That's called
Shield ulcer.
That's called shield ulcer. What are shield ulcers? Next. Okay. Come back. Shield ulcer. Suppose there's a follicle in the lip and which is pressing on the cornea. It's pressing on the cornea. It causes an ulceration in the superior cornea. It causes an ulceration in the superior cornea. And that is called shield ulcer. It responds generally to steroids. Suppose its base is clear. Then we give steroids. You can give antibiotics, but you have to give steroids because it is not infected. You will give antibiotics. So it is probably due to immune-mediated allergic, because there are toxins released from the papillary follicle which is causing this abrasion. Okay, that's how it happens. And then we give, if there is a membrane over this, inflammatory membrane, then we have to remove that. Then we have to put an amniotic membrane on that. But generally, if we see a shield ulcer, first sign is there is oral cutout. Second sign of shield ulcer is it is in the superior cornea. It is in the superior cornea. Third, once we just reverse the lid, we see the dorsal conjunctiva. There are papillary follicles in it. Okay, so this is, and what is the treatment? You give steroids. It responds generally to that. But if there is an infection or there is a membrane covering it, then you have to debride that membrane, infective membrane. And you can put an amniotic membrane. So that was about the vernal keratoconjunctivitis. Next, I move to the treatment part. How to treat? How we treat vernal conjunctivitis? Don't talk of steroids. So there are two classes of drugs. We should start with antihistaminic. Antihistaminic and decongestant drug like methazolline, phenylephrine. You understand? Phenylephrine, methazolline, azilastine, whatever, all those drugs. Then once we give these drugs, we give mast cell stabilizers along with it. What are the names of mast cell stabilizers? Chromoglycine, olopatadine, or pipotestine. Okay. So we give a combination. Of antihistaminic with mast cell stabilizer. Olopatadine comes in 0.1, 0.2 or 0.7 nanomoles. So 0.1 is to be given twice. 0.2 you have to give OD. Some people give even twice. But if you suppose somebody has a condition, you should not give mast cell stabilizer because it takes time. It's a prophylactic drug. You understand? It is not a drug which is to be given in acute condition. Suppose generally you expect vernal catarrh to exacerbate in March, April. You understand? So you will give olopatadine in November, December. Suppose you start from November, December and you give mast cell stabilizers, then he may not have that severe vernal catarrh in April, May. You understand? So it's a prophylactic drug. But once in acute situation we give it, then we have to give it combination of antihistaminic with mast cell stabilizer. Understood? So mast cell stabilizers are olopatadine, sodium chromoglycine, then before testing. Okay, so these are the master stabilizers. Suppose this is severe type of vernal catarrh. There is severe type of vernal catarrh, and what defines severe? One is Conjunctivitis. One is that means more severe vernal catarrh. And number second is if there are corneal involvement, like punctate keratopathy. You understand? Erosion or in shield ulcer, that means severe type of vernal catarrh. So in these cases, we generally give what? Steroids. And what steroids we can give? We have to give mild steroids. What are mild steroids? What are the names of mild steroids? Loteprednol or fluoromethanol. We don't give generally dexamethasone, beta-methasone, or prednisolone because they are potent steroids. They can cause more glaucoma. You understand? Generally, in such patients, we give loteprednol or fluoromethanol because they are mild steroids. Suppose somebody has a very severe vernal catarrh. You are giving steroids, you are giving antihistaminic, you are giving master stabilizers, people give lubricants, you are giving lubricants, but once you stop steroids, it recurs again, congestion recurs. What you will do now? You have to add immunomodulators. You have to add immunomodulators. Two types of immunomodulators we use in vernal catarrh is cyclosporin and tacrolimus. Very good. So cyclosporin and tacrolimus. So cyclosporin dose. Normally the cyclosporin dose is very small. Okay, 0.05% in dry eyes. But in this the dose is very high. It's 2%. How much? 2%. 2% 3 times a day. Basically, they bring injection of cyclosporin, then they make it 2%, then they give. So tacrolimus comes in ointment. It comes in and it is tolerated well. It's tolerated well. So it is given BD, morning and evening. Ointment is put morning and evening. So these are the two drugs which can be given in for steroid sparing. For steroid sparing, where you want to stop the steroid, but the condition is not under control, so you are giving immunomodulators. Any other form of treatment? Can you give systemic antihistamine? Generally in eye they don't have any role. Like, what are systemic antihistamines? Loratadine, cetirizine, monticlost, whatever. Huh? In which condition they are indicated?
Allergic condition.
They are indicated in allergic condition, but when they are indicated?
Systemic allergy.
Yes. Once there is rhinitis with conjunctivitis. Rhinitis with allergic conjunctivitis. That's the only indication when you have to give systemic antihistamine. Any form of therapy more you remember? There are therapies जो होते हैं इसमें ट्रांसफर प्लेट में you can do cryotherapy. What you can do? Cryotherapy. What do you mean with cryotherapy? Frozen nitrogen. Frozen nitrogen. Any other form? One more form of treatment is you give a supratarsal injection of dexamethasone. What? Supratarsal injection of 1 cc of dexamethasone. If somebody is not responding, you can give supratarsal injection of 1 cc of dexamethasone. Or even if it is very severe, then you can give systemic steroids also. Like Vicodin contains what? Prednisolone. You can give prednisolone 30 mg, 40 mg like a systemically to control the disease. So systemic steroids or even system immunomodulators can be given, because this is an inflammatory type of disease. Lastly, we have the giant capillary conjunctivitis, GPC. GPC. There are papillae which are very giant. They are very giant. What is the cause of giant capillary conjunctivitis? It generally happens in those who are wearing contact lenses, or those who are wearing contact lenses. There is a reaction of the lens to that. And number second cause is those who have artificial eyes. Those who have artificial eyes, prosthetic eyes, prosthesis in the eye. The eye has been manipulated or illustrated, but some prosthesis in the eye has been put. That causes irritation of the tarsal conjunctiva, and that will rise the giant capillary conjunctivitis. Then third important is, suppose you have done some eye surgery, you have left few sutures here superiorly. So these are the three main causes. Number one, contact lenses. Number two,
eyelids.
artificial processes. And number third is any suture following a surgery in the eye, which has been not cut properly or which has not been buried properly. That causes irritation. And what is the treatment? So these nodules you are seeing here. These nodules. This is one nodule. This is another. This is another. This is another. These are giant type of papillae. They are giant type of papillae. That's why it's called giant capillary conjunctivitis. So how do we treat? So classically they say that they are bumps. They are bumps in the lid. They are bumps in the lid. They will cause all these allergic symptoms: itching, foreign body sensation, redness, excess mucus, swelling of the lid. They will cause all these things. How do you treat it? First, it is common in contact lens users, so tell them to remove contact lens for some time. Discontinue. Okay. Then one more advice, that you can tell them to reduce the duration of contact lens wear. Number third, you can give them advice the preservatives which are using the contact lenses. They can just change them like that. If they are using one preservative, they can change to the other preservative. Because I may be allergic to one preservative, it will not be allergic to other preservative. If now suppose it is due to prosthesis, then you have to remove that process. If it is due to sutures, you have to remove those sutures. And then if you know any other form of treatment, you can give antihistamine, you can give mass stabilizers. Okay, if the patient does not respond to them, you can give mild steroids. Then you can taper them. So this is how we treat GPC. One is atopic conjunctivitis. This is last topic. Atopic. So this is atopic keratitis. What is atopic keratitis?
Atopic local allergy.
Atopic means they have some skin allergy. Skin allergy with eye involvement. What is the difference between vernal cutout? It happens in the lower lip. It happens in the there is a fold of skin in the lower lip. What is that fold called? Demi-Morgan fold. That's called Demi-Morgan fold. And again, it has sort of the epithelial cavity, then it has mucus production. You understand? So all features of allergy can be acquired, like the vernal cutout, except that it is more common in the patients with skin allergy. It is more common in the lower lip and lower orbit than in the upper lip. Okay? I think that's enough for you. is it? No. Any query?
No, sir.